Okay, I'd like to introduce our keynote speaker to you now. You will all have heard of Dr. Burt, no doubt. He has travelled a long way to be with us today. He will be talking for an hour, and you don't want to miss this one. So Dr. Burt travelled to be here on Thanksgiving. So thank you very much, and we're really looking forward to your speech, Dr. Burt. Thank you.
Thank you, Alison, and thank you to the AIMS board and members for holding this event. And I want to thank Cassidy from Hope HSCT. Where are you, Cassidy? Yeah, an American patient support group, for being here today. So the first part of my talk is going to be about how we got to where we are today, which both Basil and John have done a very good job of summarizing. But I'm going to talk about the work I've done to get here. And that second part of my talk is going to be about the future. So a long time ago, when I started this, had this idea 35 years ago, this was the theoretical future, but it's now here, and I'm glad of that. So the first part has to do with multipotent hematopoietic stem cell transplant for immune regeneration for MS, that is HSCT. The hematopoietic, or your blood stem cell, is a multipotent stem cell. In other words, it can form many types of cells in your blood, including immune cells, as well as platelets, clot blood, and red blood cells, and so forth. But it is not a pluripotent. It's not a totipotent cell. It can't form heart or brain or muscle or other cells like that. It's a multipotent adult cell that will reform your immune system, regenerate it. And that's what we'll be talking about today. So there's a lot of misconceptions in this field. I want to make sure you understand what those are. And I'm not sure if this can... Here's one of them, and that is that HSCT is a stem cell therapy. It is not. It's an immune-based therapy. And the outcome depends in large part on the immune-based conditioning regimen, not on the stem cells. The stem cells are simply a supportive blood product to hasten recovery, okay? So it is really not a true stem cell therapy despite its name. It's an immune-based therapy. All relapsing remitting MS is treated historically and to this date with immune-based therapies. Those are what those drugs are. And the other concept is that all stem cell transplants are the same. That's absolutely wrong. The outcome depends on the regimen chosen as well as patient selection and experience. Okay, but when I talk to neurologists, say HSCT, they all think it's the same and it's cancer regimen. No. The efficacy and toxicity of ocrevus and Lemtrada and Copaxone are very different, and they know that. But everybody thinks HSCT is the same thing. It is not. It depends, that toxicity, on the regimen you choose as well as patient selection. And here's a big problem with the field, why it has trouble growing despite the patients standing up saying, why isn't everybody doing it? And the problem is that the neurologists do not know HSCT. It's some voodoo out there. On the other hand, hematologists, of which oncologists, where I was originally trained, are equally guilty because we do not know MS. I gave up oncology, hematology, transplant for malignancies to develop this field, so I learned it. But no other hematologist is totally abandoning, giving up malignancies to develop this. If you're going to be really good, you need to focus on it. So this is really the main reason there's a miscommunication. People have not made it their primary focus on both sides. All right, now, I thought this was a good quote. It's from Ann Romney. She was the wife of Mitt Romney, who ran for president of the US. He was not elected, but she has MS, and she said, multiple sclerosis is losing who you are. It's absolutely true. And of course, this is a classic MRI, and these longitudinal lesions are called Dawson fingers, and that's fairly classic for MS. Well, so I'm going to take you how we got here quickly. First, I had spent 10 years with animal models without ever doing a patient. because nobody had ever done this, we need preclinical proof. When I first started this, I didn't even know there were animal models for MS. There are indeed. We induce the disease in animals by immunizing them with myelin proteins that's within myelin that's around the neurons in the brain, and we have to use an adjuvant to stimulate it. That adjuvant is measles, mumps, rubella, tetanus, whatever. If we don't use that adjuvant, we can't cause the disease. So for 10 years, I had a T-cell immunology lab, and when you work in a lab with immunologists, there are ones focused only on B cells, only on dendritic, only on T cells. It gets very subspecialized. So I was kind of a T cell person. And I don't have time to talk about those animal models, but they were proof of principle. So the first clinical trial I reported in Blood in 2003, and we did use a myeloablative regimen that included total body irradiation because we wanted to enter the CNS without question, and we knew TBI would do that. And in our animal models, we used TBI. Our animal models said this would not work in secondary progressive MS, but we were forced, because nobody had ever done this, to start there. Really advanced MS, secondary progressive, late secondary progressive, and it didn't work, did not work. So I put in the title failure in the title of that article. I wanted everybody to know, don't do this in secondary progressive MS, okay? And I'll show you that data quickly. But the last patient in that study, we were able to get relapsing remitting, and he did phenomenally well. And to this day, he's in remission. I talked to him about 6 months ago. So then we went on to relapsing remitting, and we used a regimen of non-myeloablative, because if we move this from secondary progressive, where you're in a wheelchair or confined to a bed, to where you can still walk, we need a safer regimen. So I went to non-myeloablative, which means we don't even have to give the stem cells to recover without it, but we do, so that the recovery is faster. And the regimen was cytoxan or cyclophosphamide and alemtuzumab or Lemtrada. And it worked great, but we had a problem, ITP, and I'll show you that. But then we changed the regimen again. So initially we started up here with Cytoxan ATG TBI. We went to Cytoxan alemtuzumab and then changed Cytoxan ATG. Reported that trial in 2015 in JAMA with 150 patients, or 154, whatever, and it was remarkably successful. We markedly decreased the incidence of ITP. So then went on to the randomized trial that was discussed in 2019. And since then, we've had two good papers that I want everyone to be aware of, and that's the health economics of transplant for relapsing remitting MS, which we published in 2020, and then kind of the real world experience of everybody we've done since 2000 with these non-myeloablative regimens, and that was reported in 2021 and in the Journal of Neurology. So I will quickly show you that. This was the very first study with secondary progressive MS. And what if we look at progression of EDSS, that's worsening of permanent disability by at least 1 point. So that's significant progression when we're starting with secondary progressive. Anybody who started this treatment with an EDSS of 6 or above were progressing despite the transplant. If their EDSS or disability was less than 6, they weren't progressing, but we didn't have as long a follow-up. And again, in that study, the very last patient was relapsing remitting, did phenomenally well, markedly improved in disability, remains in remission today. But as a result of this, I knew we couldn't do secondary progressive MS. It did not cause neurologic improvement. You could argue that maybe it slowed the rate of progression, but that was never my intention. I wanted to get rid of this disease, so we changed. And again, the summary here is, doesn't work for secondary progressive MS, even with a very intense regimen. And if we're going to do relapsing remitting, we got to use a safer non-myeloablative regimen. And so I did, and this was our next paper reported in Lancet, where we used cyclophosphamide and alemtuzumab. And the EDSS, the mean, is here, these lines. The EDSS decrease, NRS, which is another neurologic disability evaluation. If it increases, it's better. Here, if it decreases, better. These are the 75% limits, and this is everybody, all the data. So you can see there was a very significant statistical improvement, and that's why Lancet published it. So we weren't there yet because, unfortunately, 14% of the patients developed ITP. We were able to correct it with steroids, IVIG, or rituximab. It went away. It never came back. But ITP is when your platelets suddenly drop, okay? And the danger is you can have a really serious life-threatening bleed. You could bleed into the brain and die, or if don't die, have a severe destruction or stroke in your brain. So I was worried people would be like me and kind of notice some easy bruising and ignore it. That's what I would do. And then that would happen. And so we started advising all patients, whatever our treatment, that if you notice easy bruising, get a CBC, let us know. We can correct it, but don't ignore it. But still, this risk was too high, this 14% risk. Now, we corrected in everybody it occurred in. It usually occurs within 2 years. One was as late as 3 years. What caused it? What was the culprit? It's the alemtuzumab. And we studied the immune system and what happens with alemtuzumab, and it was part of our regimen. Alemtuzumab is used as a drug by itself. It's called Campath. It's called Lemtrada. Unfortunately, all drugs have many names, but it's used today, and it does give ITP in patients as the sole agent. As a matter of fact, the FDA stopped the trial because of it, and then they restarted it, and neurologists check your platelets once a month after you've had it or while you're on it. The problem is, I saw a patient in clinic, and we checked the CBC after transplant. It was normal. 1 week later, a patient called me, got the CBC, and it had dropped to virtually nothing. So checking it once a month is security for the neurologist, but not the patient. This was a side effect of of Campath, alemtuzumab, because on recovery, you get a rapid increase in mature B cells, immature, that exceed normal, but the regulatory T cells are much slower to improve. They take at least a year. They can't control these new B cells, so you can get ITP. It is what alemtuzumab can do, even as sole therapies. I hope if you take it, they warn you about it and watch for it. So anyway, we switched to a different regimen, cyclophosphamide and ATG. Did 154 patients, as I mentioned, and we had these outcomes which had never really been seen except in our cyclophosphamide Campath transplant trial. From again, the marked improvement in CDSS that was stable in the whole group for out to 5 years.
Sorry, does HSCT stop smoldering MS? The background processes that are going on all the time, absent of relapses?
So a neurologist wouldn't call it smoldering MS. What they call it is PIRA. PIRA stands for progression independent of relapse activity. And that is due to that smoldering MS, those charcoals kind of just, when the fire is extinguished, but the charcoals are still burning and hot and red. That's what happens with some drugs. And I'm going to bring that up in my talk. And the drugs that notoriously do that are the anti-CD20, the anti-B cell monotherapies, ocrevus, Kymsimta. Those drugs do that. And you get that smoldering MS, and the MRI doesn't change. Because the MRI doesn't change, you're not having relapses. Neurologists give a high five to each other, but the patient will progress. That's called PIRA. And that happens because it's not targeting the T cells. Only about 4% of the cells in an MS lesion are B cells. The B cell really isn't, in my view, the causative cell. It participates. It's a good antigen-presenting cell, and it causes those marked flares and enhancement. But the T cells, they're not directing therapy against the T cells, which are the primary effector cells, and the smoldering continues. Whereas HSCT gets T and B cells. So anyway, you can see with Cytoxin ATG in 154 patients, marked improvement in disability. And again, these are the range for everybody. And so you can see it's for everybody, it's well below where everybody started. All right, so our conclusion from that is that these results finally justified a randomized trial. And that was very important because I felt the field jumped ahead to start trying to do randomized trials before they had perfected a regimen. And that's a big mistake. You need to take time, phase 1, phase 2, phase 3. If you don't have it quite right, you got to protect that, develop that regimen. And it took us this long from after animal models and different regimens to get there. So just said it. Thanks. And So then we went to the randomized trial, and because this was still considered experimental, we chose very active MS, defined as at least 2 relapses in the last 12 months, despite a first-generation DMT, Copaxone, and interferons, or 1 relapse in the last year if you're on a second or third-generation DMT, and an EDSS between 2 and 6. The control arm was the best available DMT out there. Most of the patients got natalizumab or Tysabri. Now, that's a very different control arm. To this day, all drugs are their control arm is not the best treatment out there. It is initially nothing, and now it's the weakest interferon or Copaxone. That's it, except for a Tecfidera study. But transplants always compared against the best. Drugs compare against the weakest. The reason they want to compare against the weakest, if they compare against the best, they may not get approval. So this was a very different control arm. The first time a treatment is compared against the best out there. It was highly successful. In blue is the EDSS. The lower the EDSS score, the better you are, the better your neurologic performance. And so neurologic disability markedly decreased at 6 months and 1 year, whereas in the control arm, it worsened. Now, I did build into this after 1 year, if the EDSS worsened and stayed elevated for at least 6 months, you could cross over to transplant. That saved the study because everybody wanted a transplant. However, it prevents long-term follow-up. So I felt it was ethical, though, to offer people that, but purely in terms of statistical analysis, you can't do a long-term follow-up between the 2 arms because we allowed crossover. But for me, I'm always want to do my best for the individual patient in front of me, and that's why we allowed that if you're clearly progressing after at least 1 year of standard treatment, best available. And this has already been shown if you look at time to disease progression or time to relapse, the disease-modifying therapy in the dashed lines was much worse than hematopoietic transplant. The p-values are less than 0.001. They were actually much less than that, but JAMA made us cut it off at that number. Okay, so the summary of the randomized trial is a non-myeloablative. Remember, not all transplants are the same. I do not advocate for the intense or toxic myeloablative or cancer regimens. I advocate for non-myeloablative because the rationale is totally different than for cancer treatment. So that autologous non-myeloablative Cytoxan ATG was very effective, whereas they worsened when you had really aggressive relapsing remitting MS on the drug therapy or DMTs. We had really no short-term toxicity, except one thing that bothered me is we would get fevers, and that fevers were due to the ATG, and we'd have to block it with steroids high dose, like a gram of Solu-Medrol before, and then even after completing ATG. And if you get fevers, it can cause neural injury with late worsening of your EDSS. So it's very important to block them, but then you have to expand antibiotic coverage and check for every type of infection. And that's the one thing that always bothered me is how do we get rid of those fevers? And it's unique for this. And I think because you have a leaky blood-brain barrier and you lyse the lymphocytes, certain cytokines get in and trigger the fever, and that's why they get it. And fever is bad for MS, not just a pseudo-flare, but late neurologic disability. So if you use this regimen, you have to block that fever, and I emphasize that completely. I now know a better way, and I'll tell you about that in a minute. But late infertility, of course, it's age dependent. Under age 26, virtually everybody is able to retain pregnancy, but we always recommend to store oocytes or sperm. After age 32, virtually nobody is able to get pregnant, although we've had a patient that got pregnant. There's no increased risk of any kind of heterogeneity or mutation in your child. We still have late ITP at about 2%. We haven't totally got rid of it, so I always tell patients, especially within the first 2 years, any easy bruising, get a CBC, call us. Most of the time it's totally normal, they're overreacting, but I'd rather have that than ignore it. Now here's our paper on the real life experience from 507 patients. So 507 patients, our mortality is 0.2%. So we couldn't do it with zero mortality, and you have to know that. Nobody can. The one patient died of Legionella. It turned out to be in the water supply of the hospital, in the sink, in the shower head. Totally unexpected, okay? There was another patient enrolled, not treated, who had a sickle cell crisis and passed. So by intention to treat, which is a statistical analysis, we'd have to say it's 0.4%. By treatment, it's 0.2. But this is everybody we treated. And again, I won't do late secondary progressive, but if you're secondary progressive, I wouldn't even see the people, but they'd come to us. They're still called relapsing remitting, and they were really secondary progressive. When you transition into that, I don't know, but we certainly did. Of the 500 patients, about 90 were secondary progressive, and you can see not nearly as much improvement in EDSS as relapsing remitting, a slight amount. But if we broke this group up into active secondary progressive, which had about half a point improvement in EDSS, and non-active, which didn't improve at all, there was a difference. Now, what is active secondary progressive? We defined active secondary progressive as secondary progressive MS, but in the last year, you've had an enhancing lesion on your MRI. Those people we can still help. Not as much as relapsing remitting, but we can still help them. Late secondary progressive, we can't help you, and we won't offer this treatment to you. You're now a neurodegenerative disease. Okay, if we look at relapsing remitting by the EDSS, the time you come in, I mean, here's, you can see, independent of how bad your neurologic disability, you still get better as long as it's relapsing remitting. That's an important point, but it has to be relapsing remitting, not secondary progressive. All right, so the 507 patients, our mortality, 0.2 by intention to treat, 0.4. HSCT had significant benefits in neurologic function if done in relapsing remitting, more than 1 point, more than 1.5 points, sometimes 2.5 points in patients. Active secondary progressive, we can still help, but it's more modest, just a half-point improvement in EDSS. Non-active in red at the bottom, we can't help, and we won't offer HSCT to non-active secondary progressive MS. Now, the health economics that we've reported, we looked at neurologic disability improvement, no evidence of disease, NADA3, quality of life, and costs for transplant versus drugs. Now, if we look at EDSS, this is stunning. Here's improvement in EDSS going out to 5 years. Here's the first, second, third, fourth, fifth year. Look at that in our patients. And these are the drugs. Now, this is not a comparative trial, but this is just from the literature. Most drugs do not improve EDSS in the studies. The few that have reported some improvement are Tysabri, Lemtrada, here's CARE1, CARE2, but the improvement is less than 0.2, which is no importance to a patient. The scale, minimal change is 0.5. So that means for an individual patient, it didn't change, but you do a large number of patients, you have a mean that's slightly better. So they say this improves EDSS. No, that's a statistical endpoint for a given patient. That type of change means nothing. You can't even record it on the scale. It has to be at least 0.5. On the other hand, if you look at transplant going out, and they don't publish longer outcome, you can see we had marked improvement in neurologic disability that was maintained. If we looked at NADA, no relapse, no progression, no MRI activity, transplant versus what the literature says for drugs. Well, drugs, here's 1 year for a study done at Harvard, which I'll talk about in a minute. And here are the different drugs, all at 2 years. This is a caveat. Drugs report to 2 years. They get approved, they're done. Okay, whereas transplant, we report longer, at least 5 years. And if you look out here, you can see at 5 years, what our NADA is. And drugs don't even, at 2 years, they're half of transplant. The CLIMB study is a Harvard study where what they did is they just looked at all their patients. They're not on study, they're just changing drugs, giving what they thought was the best drug for the patient. If they couldn't tolerate it, progress, they gave them a different one. And they looked at what their NADA is on the best drug they could give them. And by 5 years, it was 17% or 15. It was really low compared to what about 80% with transplant. That's NADA. So if we looked at quality of life, basically, most drugs don't even report quality of life. It's not required for approval.
or for a publication in Lancet or New England Journal to report quality of life. The few that have done so, it's because there's a small improvement. Tysabri, ocrevus, Lemtrada, small improvement. The reason I say it's small is because it's under 5 points. And the minimal change on SF36 for a patient to feel improvement in their life must be 5 points. If it doesn't change by 5 points, the patient feels no improvement. It's simply a statistical number. So that's what they're showing, a statistical number, and they call it improvement. But for a given patient, a change of less than 5 points is meaningless. Look at transplant, the change. The other thing they do in the literature is they'll report maybe the physical or mental component. Here's for ocrevus, only physical. Lemtrada does physical and mental, Tysabri physical and mental, but they don't report total. Whereas we always report physical, mental, and total. So basically, if the FDA licensing dependent on statistically significant improvement in quality of life, none of these drugs would be approved. Now, I want to go over cost. Non-myeloablative transplant, the cost, if self-pay is $125,000. For our regimen, drugs, here's the cost of drugs, 2020. I'm sure today they're much more expensive because they're going up much higher, and these are American prices, costs. They're going up much higher than inflation. But look, when interferon came to the market in 1993, it was $19,000. Here's a different interferon, it was $13,000. Copaxone was $12,000. Look at the prices today. I mean, in 2020. 100,000. And again, that trajectory keeps increasing. And what happened as every new drug came out, here's when they come on the market, they're much higher than originally, and the old drugs always increase their price to match them. So you're spending, or society is spending $100,000 a day for these drugs that do not cause a significant improvement in quality of life. Transplant's $125. So it's really a cost savings if remission is durable. And I showed you out to 5 years, our remission rate, which is about 74% remain in remission 5 years out with no drugs. So these, at least in America, are extremely expensive drugs, very profitable. All right, so I continue to perform HSCT for MS at Scripps in La Jolla. This is looking out of a patient's room. I love that the patients can have such a great place, and the family, if they're want to, can go down to the beach with the patients in the room. So this is out the room. There's a golf course and then the Pacific Ocean and a beach below. Probably my last paper in MS will be long-term follow-up analysis, because I want to look at these patients, report what's going on 10, 15, 20 years out. I have my longest follow-ups 22 years. The patient's still in remission, no drugs, got better, stayed better. And what triggered me doing that was this book I wrote called Everyday Miracles. Well, I started just randomly talking to patients to have their stories in this book with, of course, their permission, and them proving it to make sure it's accurate. And I was shocked. I'm talking to people 18 years out, and they're still in remission because we're not following them anymore. It needs to be done. I actually recently put in a grant because I want to pay. Our patients came from everywhere, every state, some overseas. I want to be able to pay for their flight and for their hotel for this evaluation, which is just really a neurologic evaluation, and then your quality of life paperwork and any toxicity they've had over the last 20 years. But I wasn't successful in getting a granting agency to pay for it. I think it's extremely important. That's the next big question. You can't argue this isn't effective. You can't argue it's not effective out to 5 years. Well, you could say, well, after that, it's not effective. But at least many of my patients are staying in remission long term. And I do want to do that. It's a matter of being persistent. I want to be able, instead of patients paying for their airfare in their hotel, that we take care of that. I think it's appropriately what should be done at this time. I think it should be a very important study if we can get a funding agency to grant that money. Caveats on this regimen. Cytoxin ATG, and I changed it a little bit. I get IVIG day 8. That's because I want patients covered for COVID. IVIG half-life is 6 weeks, so they're covered for a good 5 months after the procedure. So I added that. But IVIG actually increases Tregs and may be beneficial to this transplant as well. You must not exceed these doses, 200 milligrams of Cytoxin or ATG over 6. You can probably go to 6.5, but over that dose, you get Epstein-Barr virus reactivation, which is a whole other problem to treat. You could get PTLD. It's kind of a post-transplant lymphoma disorder. It could result in worsening neurologic disability from the fever of the Epstein-Barr virus, but you don't get it when you cap it. Details are important. Outcome and toxicity is determined by the regimen, as well as patient selection. So ATG gives fever, and we could ameliorate it with high-dose solumedrol, and then steroids after transplant, often bolus with solumedrol. You need to do it. Fever during transplant not only gives a pseudo-flare, it gives a year later, neurologic progression from axonal injury. Well, when I started redoing this at Scripps, we couldn't get solumedrol. I thought, how ridiculous, such a common drug. The pharmacy couldn't get it, so we switched to Decadron. We've never had fevers. We don't have to give steroids after the transplant, except we do still do a very low, quick taper of prednisone. And the reason is, I just stumbled onto it by necessity. Decadron has a half-life that's about 3 times as long as solumedrol, so it's covering for us. And we're actually only giving a 250 milligram equivalent of solumedrol in terms of Decadron. Decadron, we need 1,000 milligrams, solumedrol. So we've got rid of fever. And the main thing that kept me from doing this as an outpatient was fever. And the main problem with fever, besides, risk of infections, we brought in antibiotics, we culture everything, do chest x-rays, urine cultures, all this stuff, draw a bunch of cultures. It adds a lot of expense. You don't have fever, you feel good, you're walking around, and it makes the number of transfusions of platelets and the workup and antibiotics much cheaper. And it allows us now to take it to an outpatient, which would make it even cheaper for a patient. I haven't yet moved to an outpatient, but changing that subtle change from solumedrol to Decadron eliminated fever. So importantly, MS is both a T and B cell disease. Remember that, because in America, a lot of neurologists give just an anti-CD20 antibody. Here are some of those drugs: Kesimpta, ocrevus, rituximab. And what they're getting is PIRA. This, progression independent of relapses. And they have a new term, and they talk about it. But for me, I looked at that, and I'm like, whoa, 5-10 years later, these patients have progressive MS, which is neurodegenerative MS. But the MRI never changed, and they never had any relapses. And to me, it seemed obvious they're targeting only B cells. The B cells are involved, but they're not targeting the main effector cell, the T cell. That's the problem. Yet, because you get approval at 2 years, the MRI shows no new lesions, there's no acute attacks. The patient hasn't yet progressed in disability, so high five, it's a good drug. Ocrevus is $40,000, 2 weeks later, another $40,000. Every 4 or 6 months, another $40,000 forever. It's a 4-hour infusion in clinic. It's a great moneymaker. And the MRI makes you think you're doing good. But you're really not treating the disease. You end up with PIRA, progression independent of relapse activity. That's smoldering MS. And that's because B cells present antigens and further inflame the fire. If you get rid of the B cells, which are only about 4% of the cells in an MS lesion, the coals still burn. The neurons end up degenerating. And that's being ignored. I just gave a talk in Sao Paulo, and the neurologist stood up and said, no, this is a B cell disease. And I said, no. I started taking these patients who otherwise I would have called secondary progressive, transplanting, and they get better. They wouldn't if it was truly secondary progressive. And fortunately, I brought this article. It just came out in August in Lancet Neurology. And they looked at the MRI on patients on ocrevus, and they found they have burning, smoldering lesions. The title of the article is B-cell depletion therapy, which is what ocrevus is, does not resolve chronic active multiple sclerotic lesions. You have to look at paramagnetic rim lesions, and you see they're still burning, and people don't do that. So in these randomized trials, I'm very worried when they compare to ocrevus or Kesimpta. At 2 years, they're going to look dissimilar. They're not going to do the 5-8-year follow-up. Nobody does. And there won't be money to do it. So I ask in the STAR MS, because you're going to have 2-year follow-up, and then the money will be gone. It's not going to happen. Please look at paramagnetic rim lesions. That means you still have smoldering MS on MRI. Okay? So, this is the article. I recommend you get it, show it to your neurologist. Now, here's our new criteria for MS. We stopped doing it as a study because it's approved as standard of care by multiple societies now. Patients don't want to study. I was going to compare it, Cytoxan ATG to Cytoxan rituximab, because you don't have fever with rituximab, but we got rid of the fever by simply changing to Decadron. So if a patient has new onset MS that a neurologist would want to start natalizumab or Lemtrada or mammutide or ocrevus or Kesimpta for, we'll do first treatment transplant. Relapse with non-myeloablative. Remember, not all transplants are the same. If you have relapsing remitting and you have a confirmed relapse in the last year on any DMT, we'll offer you transplant. If you have PIRA, no relapses, no MRI changes, but you're still having symptoms or worsening of symptoms, as long as you're not using bilateral cane or walker or on a wheelchair, we'll do a transplant. We'll do active secondary progressive as long as you've had an enhancing lesion in the last year. You won't do as well, but you will still improve. We won't do CIS, primary progressive MS, or non-active secondary progressive MS. Those are the new criteria. So I was going to have intermission. I don't think we'll have time. I think I'll have to keep talking, but there's 2 books out there. One is a medical textbook, 686 patients, hematopoietic stem cell transplant and cellular therapies for autoimmune diseases. John Snowden's also one of the editors on that book, as well as Ricardo Siccardi, Dominic Farge in Paris, France. I think it'll help for the medical and research community, but for patients, I wrote a book for you, and give it to your neurologists and read it, because it's really a profile in courage, a profile in courage of my patients and what they went through and how they weren't improving and how they, on their own, found out about transplant because neurologists aren't telling them, and what happened after transplant with them, as well as developing this field and the symptoms of MS, as well as some other autoimmune diseases mentioned in this book. I was very fortunate because the Dalai Lama did the foreword. I highly recommend it. Every country's Amazon has it. Amazon.uk has it. So please read that. And I probably have to keep going, yes? So this is kind of the past to the present. I want to talk about the future. Okay? Here we go. Part 2. This is real stem cell regenerative therapy. Pluripotent stem cells, iPS, or embryonic stem cells. These are true pluripotent stem cells. They can form any organ in your body. Brain, heart, lung, muscle, bone, teeth, eyes, whatever. They can do that. And that's what I'm going to talk about. Now, with this, we developed a new terminology. And that terminology, which is we have 7 patents approved by the US government on this technology. They're approved. And getting a paper published is really hard. It's like getting in the UFC ring, getting the tar beat out of you. But getting a patent approved is even harder. It was horrible. After years of fighting the US government, I was ready to give up. My patent lawyer said, don't give up. This is normal. So I didn't. We finally got him. In any event, we call it transbiosis. And transbiosis is a word that means transfer from Latin and life from Greek, transfer of life. Biology is the study of life. Biosis is life. Well, anyway, we always have the impression or the belief that you go from young to old, and that's irreversible. But what I'm going to show you is it's not true. It's reversible. By the way, who is this? Anybody? Yeah, that's me. That's me at age 17. You know, what happened to me? My goodness. It's all this medicine and hard work and neglect of my body. Fortunately, because I had a good body, I think I've been able to neglect it and do good despite that. But that's me at age 17. This is where we're going to end up, all of us. Yeah. So the comment was, if we're lucky. For me, that's not luck. I want to go down fighting. I don't want to go down that way. In any event, we can change that. And I'm going to talk about how we can do it. The pluripotent stem cells that can form every organ in your body, there's two types. One is an embryonic stem cell and the other is an iPS. Well, an embryonic stem cell, basically what happens is when the woman ovulates, the egg moves into the fallopian tube. If she had coitus at the right time, the sperm meets the egg in the fallopian tube. You get fertilization, and the egg starts to divide. It forms 4 cells. That's called a morula. It continues to divide, and it forms this microscopic ball called a blastocyst. You can see it under a microscope. You cannot see it with your eye. And the blastocyst has already started differentiation. This outer layer of cells will become the placenta, trophoblasts. The inner layer are the embryonic stem cells that will form every organ in your body. Now, they can form every organ, but they can't form a placenta. So they're not totipotent. They're pluripotent. They form every organ except the placenta. But you can isolate these, grow them in culture, and form all these things, islet cells for diabetes, so forth, neurons for MS, all these things. The other way of doing it is you can take any cell. You can take your skin cell at any age, and you can genetically reprogram it with a cocktail of factors, of genes, back to the embryonic state. That's called iPS, okay? That reprogramming technology was invented by a Japanese gentleman, Yakamura. He got the Nobel Prize for it, but a lot of people are working with it, and those how to reprogram has been really finessed since then. And we're doing it. But the nice thing about this approach, there's no ethical concern. This approach, there's an ethical concern that you're destroying a potential life, okay? Going down this road, you always get involved with controversy, even if you're doing good. I don't want to start with a good part of the world feeling it's controversial, so we'll use iPS. Besides, I tend to see both sides of the argument, very much so. In any event, here's reprogramming methods to do it that's been refined over the decades. You can use viral vectors to do it. I don't want to use viral vectors because I don't want, in transferring these iPS cells, to give someone a virus, especially a virus that's not generally in the human population, such as a Sendai virus. You can do it without viruses now. Here are the different methods to do it. And we've done it, and we don't use a viral vector, okay? Now, here's the key to transbiosis. Your embryonic stem cells only exist from day 4 to 7, maybe day 8 after conception. That's it. They'll form every cell in your body, but we all had them, but just for a few days, as a blastocyst. As soon as the blastocyst enters the uterine cavity and implants in the uterine wall, the embryonic stem cell disappears. It starts differentiating mesoderm, endoderm, ectoderm to form different organs, and then differentiates from there to form you. But nature will not keep them around. And there's a reason nature doesn't keep them around. Their power is also their danger. They're going to form a disastrous cancer if they keep them around, okay? We can take an adult cell, your skin cell, genetically reprogram it to an embryonic state. Now, the older you are, the harder it is to do. So the younger the cell, the easier, but it can still be done. The efficiency is lower, but it can be done. The key for transbiosis, before we use it in vivo, before we inject it back to you, we inactivate it. So it can't replicate, it can't divide, and in fact, it's going to commit suicide. So you get the benefit from it, but it won't hang around, okay? That's the important part of it. And in fact, let me go back and show you. Everybody out there is wanting to differentiate these cells into these adult cells. The problem is when you have MS, if you put a neuron in your brain, it doesn't know what pathway to follow. You're not going to get better. It can't. It can't follow those pathways anymore. Your tissue is there, or scar tissue, or whatever. So my focus is not that. My focus was to study this iPS or embryonic cell. and see what's different about it and how we can use it. I don't want to differentiate it into an adult cell. I want to use it as it is. And that's the key. Inactivate it before you give it in vivo. Now, are iPS cells different than embryonic stem cells? We're running out of time. They're basically not. Now, there are subtle differences. I don't have time to talk about that. But, morphologically, phenotypically, functionally, genetically, differentiating in all three germ layers, giving rise to a new animal, they're all the same. It's called tetraploid complementation. They use the term tetraploid complementation because if you're going to make a new animal, the embryonic stem cell cannot give the placenta, so you have to provide kind of the placental cells. And then the embryonic stem cells with those placenta cells will make a whole new animal, or potentially human being. Okay, what's important here is that the embryonic stem cell, or iPS, reverses the biologic aging clock. Okay, so the aging clock, how a cell ages, is beginning to be understood. And one component, just one, of the biologic aging clock is DNA methylation. Your genes get methylated. And there's a certain pattern associated with aging that progressively continues. The embryonic stem cells and the iPS cell, the aging clock is at 0. And if you take an adult cell and convert it to iPS, it resets the aging clock to 0. You can reset physiologic aging to 0. Unlike chronologic age. In fact, it happens all the time. If an 80-year-old man marries a 20-year-old woman, they have children, his sperm, the biologic aging clock is 80 or maybe 60. It varies by people, but he's old. The cellular biologic clock, DNA methylation. But the baby lives a normal life and ages normally because during that day 4 to 7, the embryonic stem cells, the pluripotent cells, reset it to 0. That's the power of these cells. We do have immortality, just not as people. We pass it on to the next generation. But it can be manipulated so that we can still do that to this day. Taking your adult cell and converting it to an iPS is resetting the aging clock. That's what's going on. So here's the secret. Increasing metabolism and cellular and DNA repair while decreasing all the inflammatory pathways and reversing aging are all interrelated in an embryonic stem cell or iPS transcriptome. Transcriptome are the gene expression of those cells. So we have about 100,000 genes. 30,000 of them are expressed into mRNA to make protein. What the other gene's doing isn't really clear, but they're doing something because nature's never wasteful. And in fact, on analysis, careful analysis, about 8,000 of our genes are viral genes that we've incorporated and kept in our DNA. It means viruses may not be all bad. A cell wouldn't keep it if it wasn't of some value. So they're beginning to understand now how these genes that aren't transcribed, which are most of our genes, are actually important. But that's a whole nother question. Of those that are transcribed, when you change the transcriptome to an embryonic stem cell, you can reset the aging clock. You can markedly increase metabolism and decrease inflammation. So if we treat the cells so they won't continue to live, they just live a few days and they're gone, you can see here how we showed that they won't proliferate and they won't survive beyond 168 hours, depending on the dose of radiation we give them. There's other ways we've done it. And that way we know they're not going to continue to cause problems. Very powerful cell. Nature doesn't want them to persist because they'll cause problems. So we make sure they're not going to persist. But then if we use them, they're still alive or dying. They're still alive but dying. They're already dead but not totally lysed. And we treated animals with acute infarct, leg ischemia, spinal cord transection, radiation injury, wounds, bone marrow transplant with or without the cells. And we also treated old animals and looked at their cognitive skills afterwards, as well as the cardiac function related to aging. Did it improve? And in all these cases, it improved. and we never got a tumor. The key is you can't let these cells live more than 18 days, somewhere between 14 and 18 days. As long as they're not going to live longer than that, they will repair your tissue and they won't cause a problem. And they'll help reset your aging clock. We can make animals more intelligent. We can make animals younger. We have patents on that now, besides repairing tissue. Can we do it in humans? Well, 35 years ago, I spent 10 years in animal models for going to patients with autoimmune disease. So that's where we want to go. It's a whole nother set of hurdles. Here's acute infarct in a mouse on a respirator. And here's after transplant. Basically, what it just shows is compared to controls, when we used, in this case, embryonic stem cells, we had marked improvement in heart systolic contraction and relaxation compared to not giving that after the infarct. Here's survival after total body irradiation. It's kind of like a Chernobyl event or a dirty nuclear bomb. You're not going to be vaporized, but you're going to die because your bone marrow is going to give out. Your gut's going to start giving out and bleeding. Rapidly proliferating cells are going to be dying. We found if we did a transplant after total body irradiation, we added back to the bone marrow, we added these IPS, or in this case, radiated embryonic stem cells. We can also do it with lyophilization. It's a particular trick. So we can lyophilize them to a white powder and it still works. That we can save these animals with low doses of the bone marrow given back, the bone marrow or hematopoietic cell, much lower, and they wouldn't survive if we didn't give them. Here's where a wound is. This is 2 weeks after a wound. On the one side, we only gave the media. And on this side, we had a one-time injection of the media with our irradiated embryonic stem cells. And you see 2 weeks later, it's markedly improved compared to without it. So how does transbiosis? Now, there's a lot of animal experiments. They're in the patents. I haven't published in the medical literature because if you did, you couldn't patent, and I need to go back and do that in the medical literature. But this is basically, I can't go through all those. We don't have time. How it works, it upregulates metabolism, DNA synthesis, cellular repair, downregulates inflammation, and reverses cell physiologic age. So I want to talk about how do we know that? We did microarray analysis of all 30,000 genes. The problem with that, you get too much information. I can't look at 30,000 genes. So you have artificial intelligence programs do that for you. And it showed us, here's some of these genes with a heat map. It showed us that top 20 most upregulated signal pathways are all have to do with cell metabolism. They increase it, they upregulate it in the damaged tissue that got the treated cells compared to the damaged tissue that didn't get our irradiated embryonic stem cells. If we looked at the top 20 most downregulated signal pathways, because genes, the proteins of which can go in many pathways, you can see it's downregulated. 10 minutes is what they're telling me. If we looked now at aging and intelligence, I call this Flowers for Algernon. It's a book about how you can make mice more intelligent. They did it with humans and then it didn't last. But in any event, it's not a true story, but it's a great movie and a book. We do make mice more intelligent. This is a study. I don't have time to talk about it. I call it my Flowers for Algernon experiment. Here's the important point. We all know this. It's right in front of us. Whales out there live beyond 200 years. A dog, 10 to 13. A mouse, 18 months to 2 years at most. A human, 70 years, maybe 72 years on average. The aging difference is due to chromatin remodeling that alters epigenetic and cell age. And transbiosis alters that. So what do I mean by epigenetics? Epigenetics is how you change DNA and the expression of genes without changing the genes. And that can be done by modification of the histones. Histones are these proteins that DNA wraps around, so all these genes can be put in this little nucleus inside this little cell. And modifying them by methylation, acetylation, ubiquination, or phosphorylation totally changes how those genes are held to those proteins, which changes their expression, and also that those changes correlate with aging. It's not as well as understood as the methylation of DNA. But if we look at methylation of DNA, there are aging clocks. The most common is known as the Horvath clock. named after the investigator who discovered it. And basically, if you look at progeria, a 12-year-old boy or girl who looks 60, their methylation clock is of a 60-year-old. If you look at an old person out here who looks pretty good, there are people 60 look 40. Their methylation clock is a 40-year-old. You look at a 60-year-old who looks 80, their methylation clock is of an 80-year-old. The point is, it can reverse. The methylation can and does reverse on the DNA. And the clock, it's not an increase or decrease in methylation. It depends which gene you're looking at. So they look at 300 different genes, a little more than that, and compare the patterns with age. In any event, our treated cells, we have tons of changes in histone modification. I don't have time to go through that. I'm just going to show you DNA methylation changes, which are key in changing the aging clock once we treat cells with this. But importantly, look at this. The zinc finger scan domain 4C gene, that inhibits maintenance DNA methylation to facilitate telomere lengthening. And we've known for a long time that the length of the telomere at the end of chromosomes correlates with aging. All right, transbiosis, I'm almost done. It's independent of your differences in immunology. It's a universal stem cell, a universal help cell, can treat everybody. It's not going to cause you a problem. It's okay if your immune system attacks it, because we've already pre-programmed it to die. It undergoes apoptosis but repairs the host. It provides transient metabolic anti-inflammatory factors and provides an epigenetic or aging reset, partial, to damaged tissue. Here's our cell line. We've already trademarked it. We call it my cell. It's Portuguese for mother cell. That's an actual picture in our GMP facility. I chose the word my because it's a root word. All languages seem to have a very similar word derived from whatever our common heritage was, my being Portuguese, but you can see here different languages, the root word for mother. Oh, by the way, the company we established, it's called Genini. And you see we trademarked our symbol, an egg with DNA at the back. Do you know anybody know why I called it Genini? Well, Genini is ancient Sanskrit for, Genesis or creation of life. But there's another reason. Spell that word backwards. In an egg. So creating new things gives you an opportunity to do this. Once you're down that pathway, you're kind of stuck. So this is the time to do new things. Okay, how does it work? The pluripotent transcriptome of day 4 to 7 of embryonic stem cell or an iPS cells are the fountain of youth. Ponce de Leon looked for it throughout the Caribbean, but it's kind of there in front of us, inside us all the time. I always thought God has a sense of humor. We just can't laugh at ourselves. It is why old parents have a young child. It is how we reprogram an adult cell into an iPS cell, and when doing that, it takes an embryonic stem cell physiology and shape and function, the aging clock gets reset. It's why when we culture embryonic or iPS cells in culture, I've done it for up to a year, over 100 passages, as long as they don't differentiate, their aging clock remains at time 0. Once they start to differentiate, it takes off. And it really, accelerates. And actually in human beings up to about age 10, it's accelerating rapidly, the aging clock, and then it slows your teenage and middle age years. After age 60, it starts taking off again fast. All right, so where it all started, not too far from here, Cambridge with the DNA double helix was discovered by Watson Crick in 1953. I spoke there once. Sir Ian Wilmot was the other speaker. There's only 2 of us. Sir Ian Wilmot cloned Dolly the sheep. For doing that, he was knighted. That's why he's called Sir. In America, we use the word Sir, but it doesn't mean anything over here. It means you were knighted, and so you call him by the first name. Sir Ian, he's the most down-to-earth guy. He took me to the pub here, the Eagle pub. There's a little plaque right here. It's in honor of Watson and Crick. And there's a particular table in there with a little plaque because that's the first place, Watson and Crick, to a bunch of students going to a pub they love to do, like John, and John took me to a pub last night, to a bunch of students, and postdocs, and other people announced they discovered the double-strand helix of DNA. So now you're learning about transbiosis. So here I go again, down a new path. California iPS cells kill switch. It's another book I've been asked to write. I've already done 5 chapters. The importance for anyone, including the AIMS or Hope HSCT, or anybody doing anything, success depends on commitment, persistence, and one step at a time. Thank you.